from this picture showing the vascularization of the disc and vascularization elsewhere in prolonged diabetic complication. Carotid artery occlusive disease is the most common one and the most misdiagnosed because of the atypical presentation may be presented with low IQ. Second, central retinal artery occlusion is the iris nevascularization from 1 to 5% in this patient is the rare event for the complete atrophy of the retina. Tumors are the choroidal metastatic tumors, large posterior or equatorial melanomas, and large executive retinoblastomas. The pathology of neovascular glaucoma. The nevascularization process begins at endothelial budding from capillaries of the minor arterial circle at the pupil and posterior periphery. Histologically, once the process starts at pupillary margin, new endothelial buds may appear anywhere in the iris. Anatomically, the new vessels are not on the surface of the iris. Actually, they are beneath the layer of mycotic clots. This cardiovascular membrane consists of proliferating microclots, which are clinically transparent. Before total sonical angle closure, the membrane can obstruct the trabecular meshwork, producing secondary open angle glaucoma. The vascularization process is stopped, for example, after PRP, the new vessels will focus, while the sonical angle closure remains. This is the peripheral anterior synechium, and this is pseudoangle, which is composed of creeping of endothelium and lasment membranes over the peripheral anterior synechium, making a mistaken of normal open angle, pseudoangle. The pathogenesis of neovascular glaucoma is seen of the retina liberating angiogenic factors that diffuses forward and causes nevascularization of the iris and nevascularization of the angle. The angiogenesis requires 4 basic steps. First, endothelial recursive cells derived from hepatopoietic stem cells and recruited at the site of the new vessels. Second, the pre-existing blood vessel walls are broken down to make transport budding for nascent blood vessels. The endothelium proliferate and migrate to the new vascular meshwork. The new vessels mature through addition of other cells like pericytes. The vascular endothelial growth factor gene expression is induced by hypoxia, protein kinase C activator, and mechanical stress to RPE, which is secreting it. In patients with anterior segment disease or uveitis, it was found that VEGF also produced by medial tract, severe epithelium. There are other factors like insulin-like growth factors 1 and 2, insulin-like growth factor binding proteins 2 and 3, platelet-derived growth factor, pro-inflammatory cytokine, and interleukin 6 that is proved now to be other angiogenic factors. Diagnosis of neovascular glaucoma. Neovascular glaucoma is often present with acute onset of pain, tearing, redness, blurred vision, diminution of vision preceding pain and redness 4 weeks or months. The clinical course, the pre-radiologic stage, not yet neovascular glaucoma. In patients with diabetic retinopathy or central retinal vein occlusion, there are chances to develop neovascular glaucoma. There are additional circumstances that favor the production of neovascular glaucoma like vitrectomy and lumpectomy. Pre-glaucoma stage, radiologic iris stage, characterized by movement, intraocular pressure, slit lamp by microscopy reveals dilated tufts of pre-existing capillaries from the circumferential artery of CBD. Although nevascularization of the iris precedes nevascularization of the angle, new vessels may occasionally be found in the angle without evidence of nevascularization of the iris. Open angle glaucoma stage, the reduced iris is more prominent and florid at this stage. The aqueous often reveals inflammatory reaction. Glaucoma results from obstruction of trabecular meshwork at this stage by the transparent fibrovascular membrane with variable contribution of the hemorrhage and inflammation. The angle closure glaucoma stage. Stroma is flat and smooth due to the traction. Ectopenia B is frequently present. Patients may present with dramatic onset of pain secondary to elevated diabetes. Peripheral anterior synechial formation with total synechial closure of the angle, reduced visual acuity up to counting fingers, corneal edema, and inflammatory cells in the AC. Glaucoma is severe and usually requires surgical intervention. The examination of the anterior portion of the eye by Sturgeon shows thin vessels, conjunctival hyperemia, corneal edema, occasional KPs, cataract, deep AC, bullous keratopathy in the cornea with flare and cells, and ectopia myopia. Pupillary reaction, the patient with marked relative atrophy pupillary defect are likely to develop rhodiosis, late stage of ischemia. Angle of anterior chamber, gonioscopy, follow-up must be done to central retinal vein occlusion or severe, not proliferative and proliferative not. The first line of gonioscopy is fine arterization of vessels extending from cerebral body anterior to sclerospur and trabecular stroke. Intraocular pressure early stages is not high, or later may exceed 40. Fundus examination, frequently there is associated signs of central retinal vein occlusion, there is retinal vein occlusion, with intraretinal hemorrhage, vitreous hemorrhage, and peripheral retinopathy. The optic disc may have shunt vessels, hemorrhage, pallor, and edema. Investigations, imaging studies, fluorescein angiography of course. It's very beneficial in early diagnosis of neovascularization of the iris. Iris fluorescein angiography can detect neovascularization of the iris at least 1 month prior to slit lamp. Neovascularization of the iris shows tortuosity and leakage. Iris fluorescein angiography may be performed at the same time as fundus angiography. The more specific test for neovascular glaucoma is going fluorescein angiography. Electroretinography measures degree of retinal ischemia. OCT is observed for grade of neovascular glaucoma. Grade 1, there is no modification in the angle. Grade 2, the iris is slightly hyperreflective. There is secondary to neovascularization. Grade 3, Grade 3 is a thickened, hyperreflective iridoconium angle with possible iridoconium synechia. Grade 4 closed iridoconium angle. There is iris contraction, tropinopia. Differential diagnosis, it's commonly been stuck with Fox heterotrophic iridocyclitis because of presence of nevascularization of the iris, vascularization of the angle, and open-angle glaucoma. Exfoliation syndrome, where there is very fine vascularization of the iris. True neovascular glaucoma has not been reported. Acute iridocyclitis, which is inflammatory conditions of anterior segment that can cause prominent iris vessels that are sometimes impossible to differentiate clinically from vascularization of the iris. Acute angle closure glaucoma, trauma and hemorrhage. The treatment? Prevention is the best for neovascular glaucoma. General principles for treating patients with neovascular glaucoma is identifying the etiology and the systemic workup for the diseases like diabetes, causes of central retinal vein, carotid artery occlusive, and central retinal artery occlusive. The management of neovascular glaucoma is approached through 4 stages: prophylactic, early, advanced, and end-stage treatment. Prophylactic treatments for diabetic retinopathy or recent central retinal vein occlusion patient must be screened for devascularization of the iris and devascularization of the angle. Although normal eye theater, pan-retinal photocoagulation is the most effective prophylaxis against neovascular glaucoma, according to many reports. With central retinal vein occlusion, all patients should have fluorescein angiography. Patients with ischemic time must have prompt pan-retinal photocoagulation. Patients with proliferative diabetic retinopathy are prepared for cataract surgery, should be evaluated for PRP prior to surgery to decrease chances of post-operative neovascular glaucoma. Intravitreal bevacizumab is a beneficial short-term effect injection in patients with central retinal vein occlusion. Diabetes mellitus patients with retinal ischemia must be urgently given intravitreal bevacizumab, anti-VEGF. Then PRP with follow-on medication to control IOP. Treatment of early stage. Once there is the vascularization of the iris, without the vascularization of the angle, the early therapy is PRP. The paradigm photocoagulation. This focus shows that towards and the second vascularization of the iris and during the leakage, after 1 month of PRP, decrease the vessels and decrease the leakage in the venous. It causes regression of anterior and posterior segment neovascularization. PRP may reverse the increased intraocular pressure, provided trimetrial closure not exceeding 270 degrees. There is reflux hours free. Commonest cause of failed PRP is inadequate photocoagulation. PRP can be delivered in 3 ways: plus-time delivery, indirect laser, or in the laser at the vitrectomy. In the photocoagulation, when it's not possible to perform adequate PRP during the photocoagulation, organ in the photocoagulator is effective from mid of the vitreous. And the photocoagulation can be performed transpitally with indirect ophthalmoscopy. It can dilate the pupil by treating margin of iris sphincter. Pan-retinal therapy is alternative to PRP in cloudy media or video PRP. 32 cryoapplications are performed under direct visualization. Pan-retinal therapy causing more inflammation, blood-retinal barrier breakdown more than PRP, fractional and exudative retinal detachment, and vitreous hemorrhage. Going photocoagulation, it is direct application without the laser to the neovascularization of the angle. PRP has not been successful or not possible for this to are doing the gonu, but it's most effective to be applied before development of neovascular glaucoma. This is better because it's not preventing synovial angle closure and it's no longer commonly used. The medical treatment, when IOP begins to rise around the early stage during open angle glaucoma, we are giving aqueous production decreasing measurements like topical and oral, carbonic anhydrase inhibitor, topical beta blockers, alpha-2 agonist, and rimonidine. Topical atropine 1% to decrease the congestion, and steroids for anti-inflammatory. The photodynamic therapy with verteprofen. It's beneficial to obliterate the vascularization of the iris and vascularization of the angle and to decrease IOP. Anti-angiogenesis, it's reported that systemic squalene could prevent the vascularization of the iris and effective in regression of the new vessels. Crystalline cortisone, patients receive intravitreal injection of crystalline cortisone show pronounced decrease in rubeosis iris. Anti-VEGF, the most commonly known is the bevacizumab, Avastin. It's humanized monoclonal antibodies synthesized using recombinant DNA technology against all unborn object A. Shahar et al. 2006 recommend a high dose of 2.5 milligram of intravitreal injection if the treatment is for neovascular glaucoma. Intracameral bevacizumab prior to filtering surgery decreased neovascularization and IOP after 4 weeks of administration and effective in preventing intraoperative and post-operative bleeding. Kotasha et al. 2011 stated that intravitreal bevacizumab of dose 1.25 milligram monitor for 6 months for phase 4 IOP and neovascularization of the iris. Surgical intervention is done when needed. Rapid transient decrease in the vascularization of the iris occurred, subjective phase 4 significantly decreased 1 week after injection. Visramethana showed that after single intravitreal injection of bevacizumab, full field ERG showed decreased photoreceptor function in neovascular glaucoma patients. Hegashar et al. 2011 stated that central retinal artery occlusion is a common complication following intravitreal injection of anti-VEGF in patients with neovascular glaucoma where the cause is ocular ischemic syndrome. Intravitreal injection of anti-VEGF should be performed with consideration of risks and benefits. Strict follow-up examination, especially in high-risk patients. Ranibizumab lucentis is antibody fragment of bevacizumab that binds to all other forms of VEGF also. Its affinity of ranibizumab bevacizumab to VEGF is 5 to 10 folds more than bevacizumab. The beta-frame is the new selectively binding one. It binds to VEGF-165, which is responsible for the pathological ocular revascularization with very high affinity. So there is less interference with the physiologic functions of other ion forms that are making neuroprotection for the retina. The advanced stage. PRE, if possible, or PRC should be performed to eliminate the stimulus, regression of neovascularization of the eyes within days, but financial angle closure cannot be associated. The medical treatment is temporizing until more definitive treatment is taken effect. Osmotic agents to clear the cornea and conventional surgery is recommended to be done with antifibrotic agent. Dr. Kawas A. 2010 recommended trabeculectomy with multimycin C after an adjunct treatment with intravitreal bevacizumab and PRP. Also, BR 2011 stated that trabeculectomy with multimycin C for decreasing IOP success rate was 62.6% at 1 year. After 5 years, it decreased to 51.7%. Valve implant surgery. These are the types of drainage devices: double plate Latino, broken valve, Bergel, shunt, and active valve shunt. The number of devices: Mutino implant, it is 70mm square double plate implant, has right and left eye models. FDA et al. Stated that Mutino implants maintain or improve vision in 39% of eyes. Bergel's implant is flexible electrical silicone rubber, available 150 and 150mm square size, can be implanted through porcelain. The Express miniature shunt, it is stainless steel non-valve. It resembles a small arrowhead, 3mm metal device. It has short shaft, central hollow lumen. It's 400 micrometer in external diameter of 27 volts. Post-operative complication. Post-operative hypotenuse is severe, 91%. Choroidal detachment, 27%. Suprachoroidal hemorrhage, 18%. Fewer complications if conjunct with better surgery. The valve devices: Kruppen valve, silicon tube slit valve connected to oval plate area 1.3mm square. Ahmed valve. It's a silicon tube attached to either single 184mm square polypropylene plate or 364mm square two plate virgin, effective in decreasing IOP with no incidence of complications associated with hypotony. The end state where there is total anterior synechium and synechial angle closure and no missile vision. The control is our aim. Medical treatment: topical atropine sulfate 1% 2 times per day and topical corticosteroids 4 times per day, and cyclodestructive procedures. It's either cyclocryotherapy, like Krasner P. and Eckhart 2003 said, cyclocryotherapy for 51 eyes with neovascular glaucoma. The mean IOP decreased from 43.6 plus or minus 13.4 millimeter mercury preoperative to 23.6 plus or minus 11 millimeter mercury 1 week post-operative. Complications include decreased visual acuity up to 2 or more snellen noise in 40% of cases, up to no PL in 25.4%, chronic hypotony 33.3%, and titus bulbi in 13.7%. Retreatment was performed in 6% of cases. Cyclophotocoagulation. It can be done with transcranial cyclophotocoagulation. This is scanning electron microscopy of northern ciliary processes adjacent to pars plana and iris stroma. Scanning after cyclophotocoagulation, transcranial, treated ciliary processes showing extensive architectural destruction extending into pars plana and iris stroma. Normal ciliary processes are visible adjacent to treated area. The ciliary body is ablated using diode laser beam. There are 4 approaches of cyclophotocoagulation. Either non-contact transcranial cyclophotocoagulation, which is indirectly through the air, or contact transscleral cyclophotocoagulation directly through a fiber optic placed in contact with the eyeball. Transpupillary cyclophotocoagulation, endoscopic cyclophotocoagulation. This cyclophotocoagulation is applied for patients on maximum medication with inadequate control. Filtering procedure obtains low visual acuity and optical. The endoscopic cyclophotocoagulation with conjunction with cataract surgery shows good success rate, relatively low complication rates, but serious complications are hypotony, transcameral macular edema, and retinal detachment. Transpupillary cyclophotocoagulation, advent laser beam on ciliary processes by indirect gonioscopy, require transparent cornea and dilated pupil. It is seldom effective in decreased IOP. Ultrasound therapy, cycloscleral trunk therapy, high intensity ultrasound. It has a higher rate of success and fewer complications than cyclophotocoagulation. Retrovalvular injection to loss preserve. Local anesthesia and retrovalvular space can be of absolute advent, useful in relieving pain. To sum up, neovascular glaucoma results from loss of fibrovascular tissue over the iris and trabecular meshwork. Vision produced by hypoxia and retinal neovascularization diffused into anterior segment causing oculis iris. Neovascular ischemic retinal venocclusion, diabetes retinopathy, radiation retinopathy are the common causes. Clinically it has 4 stages. Clinically it has 4 stages: pre-rhodiosis, rhodiosis, iris, open-angle glaucoma, and endocranial glaucoma. Diagnosis of neovascular glaucoma, assessment of IOP, slit lamp, gonioscopic exam, fluorescein angiography, OCT, and ophthalmoscopy. Prophylactic treatments are treating ischemic area by PRP, immediate clear, pan-retinal cryotherapy evocate. Management of neovascular glaucoma is by attacking ischemic retina by PRP or PRC, vascularization of the iris, intracameral anti-vision, endoscopic photocoagulation or photocoagulation. Intraocular bevacizumab has a beneficial short-term effect. Medical treatment, control of IOP and quieting the eye before surgery, conventional filtration with anti-metabolized angle closure and remaining useful vision. First of choice is aqueous drainage tube shocks. Cyclodestructive procedures in failure of valve shock, in end-stage neovascular glaucoma, retrovalvular alcohol injection, or even inoculation. Thank you.